Well, thank you very much. Cheers. Before you go, thank you, Harry.
I'm not going.
Wanted to thank you for inviting us to present here at this excellent meeting. And we were asked if we could already give a lessons learned presentation, and I think we can. We have large database with and around 3989 from the two studies, Reef-1 and Reef-2. And on behalf of the study teams, we did a very close look into exactly the question, what is the contribution of 6379 to the antiviral activity of our siRNA 3989? These are my disclosures. I work for Janssen and J&J. And we had shown exactly this cartoon 3 years ago in this room when we were announcing the plans for the Reef-1 study, the rollout of the Reef-1 study, where everything was centered around the yellow cross that you see, the blocking of all viral transcripts with the siRNA 3989, but where we had obviously a red box, nucleoside analogs, and two blue mechanisms of actions for the capsid assembly modulator, 6379, and planning. And in particular, the further to the left, where we are expecting the blocking of replenishment of cccDNA, obviously was an interesting target and an interesting question, which then made it into the design of our phase 2b study, Reef-1. Just recently, we had the important paper on the nomenclature of the core assembly protein targeting antivirals, where we now classify the 6379 as a CAM-E. E stands for empty, whereas CAM-A would be for aberrant. We also talked about this one 3 years ago. So here, very quickly, preclinical data, AAV mouse model with HBV replication, where you clearly see to the left, HBV DNA had a additional effect of the combination, where you see in violet, the lowest reduction was in the arm where 6379 and 3989 were combined. On S antigen, you see a clear differentiation between placebo or vehicle and the capsid assembly modulator alone for the two other arms, but the combination, the addition of 6379 to 3989 did not show much of a difference if this was tested in the mouse model. So everybody has seen the design of the Reef-1 study. I saved time here, only 10 minutes in total. Important, we were testing in different colors. 3989 alone, 3 shades of blue are the 3 different doses, 40, 100, and 200 milligram. And with 100 milligram 3989 in green, we also had a triple combination where we have 6379 in addition. A triple because all arms received the nuke. And then importantly, at week 48, only patients who qualified for stopping or met stopping criteria were allowed to stop the nuke, whereas other patients were continuing with the nuke. And that is important when we combine Reef-1 with Reef-2 a little later. Very important, Reef-1 had a wide population, E positives, E negatives, not treated, and virologically suppressed. And that is also different in Reef-2. I'll get back to that. So the first thing was our primary endpoint, proportion of patients meeting these stopping criteria based on ALT, DNA, E antigen, and S below 10. And you already see here in the middle blue bar, which is 100 milligram without 6379, and the green bar, which is with 6379. And there's a typo. It shouldn't be 200 milligram, 399 should be 100. Damn. So apologies for that. It is 100, very important. You have to believe me. And the original is also using this 100. So you see that there is a numerical difference, looking like blue is doing better than green, so the capsid assembly modulator not helping. And the same thing we have seen here in the reduction of S antigen over time. You again see a nice dose response. All blue is getting further down the higher the dose, from 40 to 100 and to 200. But the green arm, when we add 6379 to 100 milligram, is not showing a better response than the medium blue. It is showing little less. This was our observation in Reef-1, and it's all discussed and published. So now we look into Reef-2. Why do we do so? Because we have, here it's correct on the slide now, we have one green arm in Reef-1 with 100 milligram triple, and we now can look at an arm from Reef-2 where we have 200 milligram with addition of 6379. And that's the purpose of the analysis today, where we are first looking at the baseline characteristics. I mentioned it's obviously not identical populations, and we enrolled Reef-2 only in Europe. We have a good proportion of Asian patients, but it is not a global study like Reef-1 was. I put a little red circles around important observations. Obviously, in Reef-2, we requested every patient was on the nuke for at least 2 years. In Reef-1, 6 months were good enough for the nuke-suppressed patients, and that may be reflected in the proportion of patients that are HBV RNA negative at entry and correlated antigen undetectable or lower limit of quantification at the entry into the study. You see that all arms in Reef-1 are having lower numbers in that, possibly reflecting that we are not comparing apples with apples here, but we are approximating, and that may be good enough for now. So what we did here, and this is new data or new look at this cross-study comparison, Reef-1 and Reef-2, we only included patients from Reef-1 that were virologically suppressed and E-negative at entry, and we see 4 lines here. First 2 comparisons on the 100 milligram we had already seen in Reef-1, so this is now focusing on the E-negative nuke-suppressed patients in dotted lines, green being triple and light blue being dual with 100, and you see now the solid line coming from the Reef-2 data, 200 milligram in triple, compared to the dotted line, dark blue is the lowest line here, where we have the dual arm from Reef-1. And here you clearly see that there is, again, an impact of 6379, not to better, but rather to less good as reduction. We have done longitudinal PK/PD modeling, and this was actually kind of confirming that what we see here is within expectation, that we really see that with the addition of 6379, the S reduction is less good in response to 3989. Now I show you also first 24 weeks of follow-up. Next week you will see the complete follow-up of 48 weeks from Kosh Agarwal. So here you also observe what we discussed earlier in the morning, that in the Reef-2 study we have a very flat off-treatment line, which is not only explained with the addition of 6379, because then we would also expect to see this flat line in the green arm in Reef-1. So in Reef-1, there were patients who stopped the nuke, but this is in the range of 10 to maximal 30% per arm, which is different from the Reef-2. Reef-2, every patient stopped the nuke at end of treatment, and I suppose we are mainly seeing this effect here as a reason for the long flat line. Very important, we have also looked at cutoffs, and you see here with the same color coding, Reef-2 is the lowest and should be now compared to the third row where the 200 milligram Reef-1. If you look at 100 milligram, it looks very, 100 units cutoff, it looks very comparable at week 48, 80 versus 71. But if you look at less than 10 units and also less than 1 unit, there is a clear benefit for the dual arm from Reef-1 over the triple arm from Reef-2, with all caveats that come with this cross-study comparison. One possible explanation would be drug-drug interaction. Only a short slide here taken from an earlier presentation. If we compare the first with the second column, then we do 100 milligram dual versus triple. And if we look at third versus fourth column, it's 200 milligram dual versus triple. And I think you all agree there is absolutely nothing on the 2 triggers which are listed in the title of this slide, which is the composition of 3989. So very likely that we're not having a direct drug-drug interaction explaining the observation. It's also important, and now we go back to Reef-1 only, that we have not seen the same effect or impact on E antigen levels. So here we look at the currently not treated patients to the left versus nuke-suppressed patients to the right. The lines are kind of all over. There's no clear inhibiting effect on E antigen. And before I close with 12 seconds left, I also wanted to show quickly lines for EGFR on treatment and off treatment, which was kind of puzzling us. We had a strong reduction of EGFR in both arms in Reef-1 that contained 6379, with a very stable reduction on treatment and a very fast increase after end of treatment. And that was now also seen in the Reef-2 study, something where we would clearly say this pattern looks more like a transporter interaction in the elimination of creatinine. All this observation only if we calculated EGFR based on creatinine, and much less so, if at all, if we looked at cystatin C in more recent studies. I don't have time for my summary, but I hope my presentation was clear. So this is for the record. Conclusion is that, as you all know, we made, based on this decision in September 21, the decision to pull out 6379 from planned, but also from ongoing studies. So we have a couple of studies that are still running, and where patients halfway through were then stopping 6379, not for safety, but certainly for this observation of potentially less effectiveness. And that is maybe the most important conclusion for my little presentation. Thank you very much.